And we'd like to welcome you to this enrichment seminar series on community-based participatory research, challenges, and rewards. Our guest speakers today are leadership from our Institutional Review Board, Dr. Robert Rosenthal and Dr. Julie Doherty. And before we get started with this presentation, I just wanted to make a couple of announcements here. I'm hoping that you can see my screen. I just want to make this announcement that we do have another enrichment seminar series coming up next month that is somewhat related to community engaged research, innovative ways using social media platforms for research participant recruitment and participation. This presentation is coming from two of our KL2 scholars, Dr. Craddock and Dr. Bremen. And you can use this QR code if you like to register for that Zoom webinar. We will have these links also at the end in the chat box if you'd like to look at those links. The other announcement I have here is that one of our ATIP awardees, Dr. Charles Hung, will be presenting at Medical Grand Rounds regarding his project Novel Drug Development Effort During COVID Pandemic, A Path to Clinic through ICTR. This third announcement I have is we're happy to announce that we are having an inaugural UMB ICTR Community Engaged Research Pilot Grant request for applications. Information about that RFA can be found here. Again, this is the QR code if you would like to use your camera on your phone to access that. We will also include that link at the end of the presentation in the chat. You can always email the ICTR navigator and we'll have that email as well here on our website. You can always email us at ictr-navigator@umaryland.edu. And with that, I'm going to move forward with the presentation. Dr. Rosenthal, Dr. Doherty, thank you so much. I know that Dr. Rosenthal will be presenting first, followed by Dr. Doherty. And if you have questions or comments, we hope that you would add them in our chat field. And at the end of the presentation, we will take those questions and Dr. Rosenthal and Dr. Doherty will be happy to address any questions you have. And I'm going to, Dr. Rosenthal, thank you.
Hi, actually, Dr. Doherty will be starting, but we'll figure that out.
Thanks so much, Wanda, and thank you to Dr. Davis for extending the invitation for Dr. Rosenthal and I to present about community-based participatory research. Next slide. We wanted to say that we have no conflicts of interest related to this topic. So our objectives today as we present is what are the differences between community-based participatory research and how it differs from standard forms of research. What is a community and how is it defined? What are the benefits of community-based participatory research to university researchers and to community partners? What are the challenges to IRBs and to the community-based organizations? And what are UMB specific policies which should be followed when submitting an IRB application? So we will be covering all that information today. So let's start off with defining what community-based participatory research is. There's many different definitions out there. This one from Advancement Projects defines CBPR as a collaborative approach to research that involves all stakeholders throughout the research process, from establishing the research question to developing data collection tools to analysis and dissemination of findings. It's extremely important that all those pieces are part of the process, because that's what makes it community-based participatory research. It is a research framework that aims to address the practical concerns of people in a community and fundamentally changes the roles of the researcher and who is being researched. And we'll get into more of a discussion about that as we move forward. So what is different? What makes community-based participatory research different than standard research? So in standard research, the PI has an interest. They ask a question, they develop hypothesis, they develop aims, they develop their research strategy, they develop data collection tools, they collect their data, and they present their results. And they do this with their academic partners and with their research team. In community-based participatory research, this approach is characterized by a collaborative partnership, which needs to be developed and fostered. There's cooperation between the academic partner and the community. And there's negotiations that go on in terms of what types of questions should be asked, protocol development. And then there's a commitment by the academic partner and the community partner to address local health issues. So it's just not one-sided. Some types of community-based research incorporate few elements of community engagement, and there's minimal collaboration. What we want to see with the development of these approaches is where the researchers are seen as equal partners with the organization, and the organization has a seat at the table in all aspects of the research. So what is and what is not community-based participatory research? So community-based participatory research is an orientation to research. It changes the role of the researcher and the researched, excuse me. So we have community-placed versus community-based. So community-placed would be the researcher going into the community and placing their research and asking that they be allowed to recruit individuals from that community, versus community-based, which is the partnership, the seat at the table, the community having input in all aspects and all phases of the research. The community needs to be a decision maker. They need to bring their issues forward. They need to be involved in the design of the study, financial aspects of the study, literally all phases. There's no aspect that they would not be a partner in. So community-based research is not a method or a set of methods. You can use many different study designs in community-based participatory research. The goal is to influence change in the community, but change that the community sees as being necessary. Are there community conditions that need to be addressed? Are there norms? Are there systems and programs and policies that the community wants involvement with their academic partner? What is important to the community? The communities can be patients with specific health conditions. They can be families, they can be caregivers, they can be healthcare professionals. You can have many different racial and ethnic and diverse community partners in many different geographic areas with many different identities within the community. When we think about community-based participatory research, some of the principles that are very important to keep in mind, and this goes from protocol development all the way through to the building of relationships with the communities. So you need to build on the strengths and the resources within the community. So you have to assess what those strengths and resources are, and every community is going to be different. Community-based research facilitates collaboration in all phases of the research. There's a commitment to addressing local health issues. So what may be deemed, the academic or academician may think that one local health issue is what is important, but finding out from the community if that in fact is true and what their local health issues are, that is what is extremely important. Bringing knowledge and gathering knowledge and action together for the mutual benefit of all partners. So gathering the knowledge is one aspect, but then disseminating the findings and bringing true change to the community is one of the principles. Academics and community learning together, with both being empowered. So you have bidirectional co-learning. The community learns from the academicians, but most importantly, the academicians are learning from the community. And the dissemination to all partners, not just collecting the data, but returning results to the community so they can see that action is being taken and change is coming to the community.
So the question then comes, how can communities become engaged in all phases of research? And it's a multi-step process, and part of the challenge with community-based research is there are many more steps in the process than a normal research project. The first issue is that people have to find partners and form a team. Then they have to form the research question. So the research question should not necessarily be formed prior to involving the research partners. The study is planned together, the research is conducted together, and the data is analyzed together, and the findings are shared. And the findings should be shared independent of whether one party or the other, wants to share the findings or not. They have to be in agreement that all these findings will be shared together. And then finally, the goal of this is that action will be taken to improve the conditions that have generated the initial question of research. This is kind of a diagrammatic plan for how to do this. And I find it kind of interesting because the first step is project design and implementation. In reality, the project design and implementation, the initial question is probably going to come from the academician or from the university. They're going to identify the research topic, the questions, the goals, and geographic focus, et cetera. So they have this wonderful idea. We're going to study project X in community Y. And so then the next step is they identify their research partners and invite them to collaborate. But it's important to look at the direction of the arrows here. Julie's already mentioned the bidirectional part of this study. So once the partners are engaged, then it goes back again for project design and implementation. So the initial project design may bear little relationship to what ends up happening. Once the partners agree on this, then they go forward with data collection, data analysis, and reporting. But it's only through these phases here where the research project is identified, the partners are identified, that you can go for and have community-based research. The important part is that in all steps along the way, all parties have to be involved, not just the academics or not just the community-based partners. So the first question we have to ask is, what is a community? And I think this is probably key to the whole process. And I mean, you can think of lots of different types of communities. You can think of place-based communities in county, city, the neighborhood, where residents have the ultimate knowledge of the issues, strengths, and solutions impacting their community. The constituents can vary within this geographic area. They could be community members, community activists, practitioners, local policy members. They could be people that are unemployed. It's the community varies. These could be problem-based. This could be medical, for example. Does not need to be medical, but for example, people living with HIV, elderly people with diabetes, sexual and gender minorities, people experience food insecurity. All these things are legitimate communities and don't have to be defined by geographic basis. Or they could be problem-based. They could be social. They could be sexual and gender minorities. They could be people experiencing food insecurity, or many other conditions that you can imagine. But the first step I think you have to do before you do any of this is define what your community is before you start planning. The big question is, why would communities want to conduct research? Well, there's a lot of reasons. They might describe the scope of their health priorities or issues in their communities. They might answer questions about their communities or service populations, might develop new programs or services. They might conduct evaluations of these programs that they might not be able to conduct otherwise, and they might be able to collect data that might help make their case for policy advocacy or funding. So there's a lot of advantage, at least potential advantages to communities that want to conduct research that use the benefit of their alliance with the academic community. What are the benefits to both sides? For the academics, the academic researchers, and the community members both need each other to address complex social and health issues. You can imagine if, Professor X goes into, community Y and says, I'm here to do this study, people will look at him or her and say, not so much, buddy. But if they go in and they establish a relationship with a community partner, it's going to make it much more helpful. Community-based partners thus enable access to communities with barriers to recruitment and participation. I think we could look at our own community in the Baltimore area and realize that there's a lot of people that are suspicious of research for various reasons that we don't need to go into right now, but that by engaging our partners within the community, we might have better access to the community and to the results. On the community partners side, academic collaboration provides them with access to university resources, money, ethical review, et cetera, et cetera. And the partnership enhances visibility and legitimacy of the community-based partners in the community. But critical to this, the mutual trust and respect, is the degree of authority over research planning, program execution, reporting of data needs to be collaborative. If any of these things break down at that point, then you lose a lot of benefits from that. What are the challenges to community-based participatory research? There's a lot, but I think you can break it down into two major areas. Number one, how can university researchers get access to communities which may be suspicious of established research practices? And number two, how can ethical and participatory research be conducted in a community where leaders don't have a strong research base? And I think that you have leaders in the community that have no idea about the Belmont report, no idea about the ethical principles of human subject research. And how do we correlate the two? How do we get the two of them to work together? These are actual quotes from different community members in one particular article about what their responses are to research. It's called helicopter research. They flew in, took our personal info, took off. We never got anything back. The academics got a grant for reducing smoking. What we're really concerned about is gun and gang violence. Did they need to do that big, long study to prove what we already knew? The professor can't just walk in here with the expectation of creating a partnership. It takes time to understand each other and make sure we won't be exploited. And finally, the university implemented and evaluated a really nice program, but then the money ended and the program right along with it. So these examples probably give good representation of suspicions that the community members might have about the motivation of the university research community and what can be done about this. And I want to go through one study and how they helped resolve this project. This was published by Hyatt in 2009. And this was a community-based participatory research project at identifying and controlling occupational health and safety risks among immigrant workers in Somerville, Massachusetts. There were 3 participating organizations. Tufts University was the academic organization, the Immigrant Service Providers Group was the community organization, and Cambridge Health was the healthcare organization. The goal was to create participatory environment within the CPVR model. In the design phase, they involved community leaders in preparation and implementation of surveys, analysis plan, and interpretation of results. And they felt the best way to survey the community was to use bilingual youths who served as teen educators acting under the supervision of experienced adult youth leaders to reach out to immigrant workers. And the resulting survey was actually developed by these teen educators under the guidance of these supervisors. So they found that in the CPBR project, there were a number of questions in the community before, like, why does Tufts require all this bureaucracy? We survey our community all the time and no one worries about this. If they answer the question, then they're giving their consent. If they don't want to answer, they won't. I wish that was that easy. That would be kind of nice, wouldn't it? I can identify the people in my organization who will want to do the survey. The consent form will just scare them away. And why do we need Tufts to approve what we're already doing in our community? Part of the issue with this is the realization that any research in the community may involve an element of risk. And one of the problems, or one of the challenges with this, is that we have to look at risks a little bit differently in CPVR from standard research, because it extends beyond the risk to the individual, but the risk to the community. And what are the types of risks that could be faced in this particular study? Well, number one, worker participation could become known to employers and lead to risks of retaliation. Employers might reveal they don't hold valid Massachusetts licenses to perform these services. There could be non-compliance with Massachusetts tax laws. Employers might not carry required liability insurance. Workers might be undocumented immigrants, and especially in this day and age, raise the risk of arrest or deportation. Teen workers might be identified as working for demand and have opposition in the community. And community organizations might be perceived as acting in concert with federal and state agencies in opposition to community interests. So how did this particular group address this project? It was a three-pronged approach. Let me just bring up all three: education, training, and dialogue. And the education was once again bi-directional. They tried to educate not only the community-based participatory researchers, but also the IRB about the role and the operation of the IRB, the history of human participant protections. And they gave examples to the community of IRB helping to identify risks that were unforeseen by researchers. And they had a discussion of the investigators' established research efforts. Training was done in research design, informed consent, and survey administration, and discussion of potential abuses and costs to study participants. And there was a dialogue, and the dialogue was bidirectional. And this addressed questions within both the community and the university about each other's capabilities and motives. And they had direct involvement of the IRB administration with community-based partners to foster understanding for all stakeholders. They actually had the administrator from the IRB, hear this, Julie, who actually went to some of the meetings of these community organizations, gave presentations there, but also listened to what the issues were within the community to help bring back to the IRB the needs and the important parts of the community organizations. Their recommendations were that from the earliest point, they should involve the community partners with the IRB as early in the research process as possible. They should meet, the community organization should meet with an IRB administrator or representative, and this could lessen the mystique of IRB oversight and help to establish trust on both sides, because it would help educate the IRB administrator. And I, along with the administrator, I put this in with, IRB chair and other members of the IRB to help understand what's included in this. There needs to be face-to-face open discussion of intention and goals, showing all parties that they share the aim of both protecting community members and giving them voice. And they need to communicate about IRB issues as often as clearly as possible with both community partners and IRB to minimize last-minute surprises. In this article, they looked at perceived barriers to CPVR success from three different perspectives. From the point of the researchers, their perceived barriers were having community partners as part of the research team. They found that to be difficult. And the reluctance, REC's is Research Ethics Committee. They say this because they had some Canadians in the study also, but REC becomes IRB. Reluctance of IRBs to approve community-based organizations outside the university settings. The Research Ethics Committee, or the IRBs, had concerns about training difficulties. How do we train these community members? Do we make them do city training? Do we do other types of training? What do we do? And there was also an administrative strain placed on the community-based organization to conduct data collection and capacity building. From the perspective of the community-based organization, they felt IRBs were slow. They were right. The IRBs have difficulty understanding CBPR. That's probably also right. And the IRBs were difficult to engage in communication. Probably all those concerns are reasonable and stuff that we're hoping that in the future, we can begin to correct, at least with our own IRB. Some of the IRB issues are that IRBs typically don't consider principles of community engagement. Even when they do a CPVR review, do they review how well does the researcher know the community, and has trust been established? And following initial approval, some of these are minimal risk. There may be no further review required, and there's no community input for regular reviews under normal situations. They looked at 19 studies, and what they found was that generally IRBs don't even incorporate principles of CPBR into consideration, even when community is engaged. This is just an example of three different studies, but let's just look at one of them, studied by Gouda. They looked at IRB forms, and what they found is that the IRB forms don't evaluate the following: community risk, community participation, need for community consent, resources of the community-based organization, and power struggles between the community-based organization and researchers. All these factors are the types of factors that we've already stated before need to be done jointly in order to have successful, to have success in community-based participatory research. So the bigger question is, we base our ethical principles on the Belmont report. And the biggest question are the three Belmont ethical principles can they be used to evaluate the ethics of CPBR? What are the principles? Principles: respect, beneficence, and justice. And the authors found that the principles don't provide a comprehensive guide for CPBR, and particularly two main principles that do not fit CPBR are respect for persons and beneficence. Respect for persons means you have to acknowledge the autonomy of the individual and protect the vulnerable population. And beneficence is to identify the risk and benefits and to maximize the benefits and minimize the risk, because they both start from the premise of an individual, and CPBR focuses not on individuals, but on communities. They found that IRBs are equipped to minimize risk only at the individual level, whereas CPBR requires minimization of more global or communal risk. So what is suggested, and actually I modified this a little bit myself, we need to expand our concept of research ethics in CPBR. And these are the things we need to look at and we need to consider if we want to consider this an ethical study. We need to look at the accessibility of findings. Are the findings accessible not only to the to the researcher, but also to the community-based organization? When we talk about beneficence, we need to talk about the benefits and risks, not only to individuals, but risk to the community. When we talked before, right, I mentioned before, the number of risks to the community and to community members that may be well outside the scope of the project. We need to look at community voice. Does the community have a say in what's going on there? We need to look at credit. Who gets credit for the research? It should be joint credit because, in fact, the research is planned by all of the individuals. Data ownership. Does the university own the data? Does the community-based organization own the data? Is it jointly owned? Is there an equitable division of labor? Is there privacy? Can we assure privacy not only of the individuals who are being studied, but of the community as a whole? How do we represent local communities? What happens if there is a negative response to the research? How do we deal with that? Do we have respect for persons? Do we acknowledge the autonomy of individuals? Do we respect vulnerable populations? Do we change our concept of vulnerable populations, not just for the ones that are mandated from federal regulations, but the people, for example, immigrants, undocumented immigrants? All these people could be vulnerable populations, and how do we provide that? And finally, we have the rigor of research and fidelity to findings. And I have to tell you, the first time I did this, when I was doing this with Julie, I called it rigor and instead of rigor, and that would be shaking chills, but actually it's rigor of research and fidelity to findings. So their recommendations were institutions conducting CBPR need to have CBPR representatives in the IRB. I think totally reasonable. If you're going to do it, have people there that know what they're doing. If we do a cardiology protocol, we want to have a cardiologist on the panel that can really understand it. We have an oncologist if we have that. This is a different type of research. It's something that we may not be familiar with. Have a person that understands it on the community, on the protocol. The IRB should reevaluate their forms to reflect these principles. And that is something that we're going to actively be doing. Look at our forms, looking at our checklist to see if we can do that. The IRB should hold educational sessions on CPPR. And this should be educational sessions, not just for the community-based organization, for the IRB, and include a CBPR researcher as a member of the IRB. Community-based organizations need to assure the IRBs that personnel conducting the research are qualified to do so or willing to complete relevant training. And one of the corollaries to this is we have to look at the training that is required of our community-based partners, because it's probably not reasonable to think they're all going to do city training. I think we all love city training, but I think we have to recognize that not everybody loves it as much as we. And university policymakers need to work to adapt regulations to the current research environment. My final, study is a study which looked at how to proceed with training of the community-based partners. In the background, they recognize the structure and time constraints of human subject research training can hinder training of community partners, aka city. The objective was to engage hospital-based IRB in implementing a brief community responsive human subject training session. Their methods were to use a 2-hour discussion-based human subject training that was developed with collaboration between the IRB and community and academic partners. And they felt that local IRBs have the potential to assist community partners in building sufficient knowledge of human subject in order to proceed with community-based training, community-based partnership. This is an example of the training that they did. The questions were addressed, the training content. What is human subject research? They defined human subject research. They asked questions. What is the design of the current project? How are data being collected? What do we mean by ethics and ethical conduct? They defined ethics. They had a history of how rules were developed, and they engaged the partners with their experience with research, the community's experience with research, and what their perceptions about research were. What are my ethical responsibilities as a community partner? And they then reviewed the Belmont Report principles. And the questions they asked were, in what ways does the research fit or not fit with our mission? And what risks and benefit does the current study pose? Then they asked, what is an institutional review board? I asked that question very frequently, but the training content was their IRB structure, responsibility, conflicts of interest, components of the IRB application, but they asked more general questions. How do you manage potential conflict of interest? Are youth vulnerable population? What are other vulnerable populations? What info is required for an IRB application? And then finally, what is informed consent and assent, and why is it necessary? And the questions they asked, what is minimum information required to give informed consent? When can we do waiver of parental consent, and what unique issues regarding confidentiality may be faced by study participants? So I think if I were to, I'm going to stop sharing now, let Julie start to share. I think if I were to sort of summarize what I said here, the important things that I would take away from this is that the community partnership has to be a true partnership. In order to do a partnership, there has to be trust between both parties. There has to be training and understanding of both parties. There has to be training of the community members, but also training of the IRB. And the IRB needs to be a little flexible. It needs to adapt their processes in order to better accommodate community-based participatory research. And with that, I will end.
Okay, thank you, Dr. Rosenthal.
Julie, click the box down below. So you have that next one over. Next one. Yeah, that one.
Okay, so thank you. So now we're going to discuss some human research protections guidance from the Human Research Protections Office and the IRB that can be utilized when you're developing your community-based participatory research. So increasingly in our effort to foster community engagement in the research process, patients and other community stakeholders, as we've said, are involved in various levels of research design and conduct. From the IRB and human research protections perspective, it's important to consider the circumstances in which these individuals may either be considered to be research subjects or not, or individuals who are engaged in the conduct of research. So we have some examples. Now, these are just a couple of examples, and kind of go through them. So you talk about a community advisory board. They could be involved in protocol development only, and you are asking for research advice and guidance. You're going to the community advisory board and asking what is important for the community to learn more about? What is important to you? What health concerns, what social concerns, health determinants are important for the community to learn more about? So then we look at, if the community board is just asking those questions or being asked those questions and they provide information, then they're in an advisory capacity only. But then we have to get into, and we need to get into asking what the definition is of a human subject. And you'll see why that this becomes important when you're looking at who is in the community, who is your partner, and who is a human subject. So this is the definition of a human subject as defined by HHS regulations. It's the new definition per the updated common rule of 2019. So a human subject means a living individual about whom an investigator, whether they're a professional or a student, conducting research, obtains information or biospecimens through intervention or interaction with the individual, and uses, studies, or analyzes the information or biospecimens, or obtains, uses, studies, analyzes, or generates identifiable private information or identifiable biospecimens. So these definitions and the exact wording within them are extremely important when we look at the involvement of the community and whether or not they're considered to either be a human subject or to be engaged in research. So we have some examples and some to help generate some ideas and whether or not the community would be considered to be engaged. So first example is to help consider whether a community collaborator qualifies as a research subject. Here's an example. So an investigator seeks to collaborate with patients who are part of a support group for cancer survivors. The investigator wishes to obtain feedback on the types of questions that should be asked of cancer survivors in an online survey to understand their impressions of their care within the health system. So first version, the collaborators will be consulted for instrument development only, and they will not be asked to provide any data from their own experiences that will be used for analysis. So as we think about that, consultation for instrument development only, and the investigator does not want to collect individual data from those people about their own experiences. So when we look at this example, these collaborators do not qualify as human subjects because no data is being collected from these individuals that will be analyzed as part of the study. It's for instrument development only. So that's one example. Then in another example, so after the instrument is developed, the collaborators will be asked to complete the online survey as these individuals meet the criteria for enrollment in the study. Data from their online survey responses will be analyzed similarly to all other respondents. So now the collaborators become research participants. So the collaborators do qualify as human subjects because they're providing data that will be analyzed as part of the study. And as we move further in the presentation, you'll see how different phases of the study change who may or may not be considered either engaged in research or considered a human subject. So there are certain circumstances where community collaborators may be considered investigators who are engaged in research. In these cases, the collaborator's role in the research must be overseen by an IRB, and the researcher would be required to complete appropriate human subjects training prior to initiating any activities related to that engagement. And that goes back to Dr. Rosenthal's description of the type of appropriate education and training that would be needed or should be developed. So generally, and this is outlined in our Human Research Protection Program plan and our investigator manual, investigators include any individual involved in the design, conduct, or reporting of research. The types of activities that might qualify an investigator to be engaged in research is if they are interacting or intervening with research subjects for the purposes of research, if they're administering a survey or performing research tests, if they are consenting research subjects for research participation, and if they're participating in the collection of or having access to identifiable data from research subjects. So some examples about whether a community collaborator would qualify as an investigator. So a researcher seeks to develop a medication adherence support tool for patients with Alzheimer's and their caregivers. In order to design the tool and the study intervention, the researcher will work with a group of Alzheimer's patients and caregivers to ensure the ideas of the target population are represented. These individuals will participate in some research team meetings and will be compensated for their time. Their participation will continue throughout the life of the study. I think this is a very good example. So in version 1, the patients and the caregivers will have no interactions with subjects, and data presented at research team meetings will be shared in aggregate form only. So the patients and the caregivers will not have access to individually identifiable subject information. So in this case, collaborators do not qualify as investigators, as they will not interact with the subjects, nor will they have access to identifiable data from subjects. So as we like to say, the devil is in the details. You have to parse out what the activities are that are going to be taking place to know whether someone would be considered engaged in research and or whether someone is considered a human subject. Another example, the study team believes that the purpose of the research study and the medication adherence tool will be best described to subjects by patients and caregivers. They have asked that their collaborators participate in the consenting process. So once you're involved in the consenting process, you are considered engaged in research. Their involvement must be overseen by an IRB, and these individuals must complete applicable human subjects training prior to initiating any activities related to their engagement. So I think these are very good examples of real world activities that can be taking place. Other things that are extremely important as you develop a protocol or as you develop a grant application is to include in these documents, what is the community involvement? You have to define the community. What community are you going to be engaged with? And what is their involvement going to be? Is it an advisory board capacity? Is it, are they going to be engaged in research? Are they going to be considered human subjects? Describe your community consultation. What's the process? How is that going to look? What's the frequency of the meetings you're going to be holding? What's the bidirectional sharing of information? Collaborative review. What do we mean by that? So not only would there potentially be the requirement for IRB review on the academic side, but the community may require a local review. They might have a board of directors, the community advisory board, or another entity that would have to review the proposal and give their approval. What is the plan for modifications to the study? This is extremely important, and we're going to talk more about how to break your grant or major award down into smaller IRB protocols so that your plan for modifications is much easier to implement. What's your plan for disclosure of the research findings? One-on-one meetings, PowerPoint presentation. How are you going to break down the research findings into layman's terms? Providing a bunch of graphs and, statistical analyses and all of that is fine on the academic side. But when you get to the community side, it needs to be described in layman's terms. And your protocol also has to describe how you're making the benefits available to the group. So you now have presented your findings. How are those findings going to translate into action? An action that is going to benefit the community. As Dr. Rosenthal had described, human subjects training. As he said, we all love city training. We all know we have to do multiple modules. A lot of those modules are not applicable and to the community and are not the appropriate type of training that they should receive. Working with a community advisory board to help ensure that the training is culturally sensitive and provided in a manner understandable to the community research partners. Is that a PowerPoint presentation? Is it a video? There's many different opportunities for development. And working community partners meeting with the IRB prior to introduction to the broader community can help lessen the mystique of the IRB, clarify goals and processes, and further develop mutual trust. It also provides an opportunity to ask questions and to understand what an IRB is, how it's composed, that there are non-scientists, there are lay individuals on the community, on the board. All extremely helpful information. So for some further recommendations from Dr. Rosenthal, myself, and our Human Research Protections Office is to consult with the IRB and the HRPO, either upon notice of award or when you're developing your grant submission or prior to your protocol development. Both Dr. Rosenthal, myself, and our IRB manager, Jan Martinez, are available to answer questions and to help with protocol development. We will be issuing guidance, a worksheet that can be followed, that will incorporate much of the information that we have in these slides to help walk through what your protocol should include. One thing that we highly recommend is breaking down your grant into multiple smaller studies. And what do we mean by that? And why do we suggest that? If you have an award and it's for a community-based participatory research approach to the research, the study and the grant will involve multiple phases. And what we have learned and what we are continuing to learn is that the phases of the research and of the grant change over time. So the initial part in working with the community or gathering information, that aspect might be considered non-human subjects research, or it might be exempt. Having the protocol broken down or the grant broken down into smaller multiple studies helps with the ease of IRB review, instead of trying to include every phase and every step in one big IRB application, which can get very confusing and involves, a much broader spectrum of information. So breaking it down into multiple smaller studies, which then reference other studies within the award, is what is recommended. Now, we also recommend working and coordinating with your project officer so that they understand that this is what the approach is going to be. Again, roles change over time. Therefore, meaning the roles of the investigator, the community, and who is defined as a research subject within that grant. Therefore, the applications will also change and mature. And as I said, could go from non-human subjects all the way up to potentially something that might be seen as greater than minimal risk. So for the IRB, the IRB is looking to minimize risks and provide benefits. Recruitment strategies, extremely important to outline in your protocol. The dissemination of results, we've talked about that. Informed consent. Are you looking for a waiver of informed consent for certain studies? Is parental permission or legally effective informed consent with a informed consent document required? The IRB is looking at distributional justice. Are the risks and benefits appropriately outlined, and is the community that is taking on the risk also the community that is going to benefit from the research results? And privacy and confidentiality. Privacy of the research participant, the data, and the confidentiality all need to be outlined so that the community is protected in their ongoing participation in the research. One of the things we've been working on with some entities on campus, including the School of Nursing, is coming up with an acceptable process for how individuals and collaborators and the community get compensated for research participation. And because we work for a public institution, there are certain requirements that have to be followed. So if the community is being compensated, or individuals on a community advisory board are to be compensated for their time, the IRB approval letter needs to accompany the comptroller exception form, and the individuals who are part of the community advisory board need to be designated as community planners. The state has an issue with the term participants, particularly if it's the aspect of the research is deemed to be non-human subjects research. So they have agreed through the local finance office at UMB that you would be working with, that they need to be deemed community planners. This will help facilitate getting compensation that's been approved by the IRB to the community. And as you know, anything we can do to facilitate processes related to getting appropriate compensation to individuals is extremely important. When we talk about the other things that the IRB is going to consider as part of the protocol and as part of the IRB review, is there evidence of an equitable partnership between the investigator and the community? Is that evident within the protocol? Have the investigators defined the relevant community or communities? Has a community co-investigator been identified? Is it necessary? Is it appropriate for this project? In some instances, it may not be necessary. Acknowledgement and documentation that community engagement is an integral part of the research. The IRB wants to see as much information to support and to document the community engagement. Letters of support from the community need to be included, and they need to be clear and well-defined. The IRB wants to see that this relationship has already been established or is in the process of being established, and you have buy-in from the community to move forward. Is there an appropriate division of funding, if applicable? Would the community be the recipient of any of the funding? We already talked about, what are the adequate training opportunities for investigators and community members? Do you want the involvement of the IRB in fine tuning that? We're more than happy to, be involved to the extent necessary. Is the research environment adequate? Is the community going to benefit from the presence and implementation of the research? And is the research conducted in an environment that enhances the likelihood of success? So this is looking at feasibility and whether or not the research will be able to answer the questions. Does the research strive for positive change in the community's outcomes? And does the research foster a long-term relationship between the university and the community for the benefit of both? This gets to sustainability. And can you maintain the relationship and maintain a presence for the benefit of both the community and the academic institution? I'd like to leave you here with some websites that we have found very beneficial. First one is the University of Nevada, Reno and UPenn, and we'd like to thank them for allowing us to use some of their resources. The UPenn resource is also utilized by Hopkins, which is our CTSA partner. So we're very happy about being able to utilize that. And just some other references that are very good and accessible. This journal, Progress in Community Health Partnerships, it comes out quarterly, and a book on Handbook of Community-Based Participatory Research. Both very good to have on hand or to access to answer many questions and to get some good background on. Now I'll hand it over back to Dr. Rosenthal.
Well, we want to thank you for taking the time to listen to us. What you see before you is a map of Baltimore that talks about the food insecurity and life expectancy depending on region in there. And I think we have to recognize that we are part of the Baltimore community, and this would be an example of something could be doing that. And if I can put an editorial comment of my own, I think we also have to recognize that we are part of the world community. And I personally want to send out my hopes and prayers to the Ukrainian people today, and recognize the difficulties that they're having, and hope if there's anything we can do to help, or we can do to make their lives easier, that can help also. So thank you all for listening. If there's any questions, please feel free to address them to us, or Julie and I are always available if you would like to, if you'd like to speak with us, at a different time.
Thank you, Drs. Doherty and Rosenthal, a quite extraordinary presentation. And I know the amount of thought and work that's gone into this, and greatly appreciated. And we've learned a lot. And so apologies, I'm going to go to my 1 o'clock Zoom, but we really, really enjoyed and appreciated your presentation. Thank you so much.
Thank you.
Hello, everyone. So sorry, I was trying to figure out how to get my video just turned back on. I do have a question for you, Julie, Dr. Doherty. I noticed that, and actually some of us in the ICTR noticed that City has added a community engaged research, community-based participatory research in their modules. Is that available for the UMB community for the campus? Is that one of the items that is on the subscription list?
If it isn't, it can be made available.
Okay, great. I just sent the link to you. I know in the past, I discovered that there were some modules that were available to our community, and I went ahead and purchased it. And then I found out subsequently that it was part of our package and that our campus had subscribed to that. But I just sent you the link for that. And maybe if that's added to our campus subscription, then we can get that information out there too. I know there have been some questions as well about the slides being available, recordings being available. And yes, we will be sending links to the presentation and the PowerPoints to those who participated today, as well as we'll be putting them on our website. That takes a little bit longer, that's for the general folks to see, but those who took the time to be here today will definitely send that out to you. I think there was one of the things that has come up in the researchers as they're engaging with the community. They've had questions about the informed consent in engaging people, especially in this time of COVID. And I know that we don't have much time to discuss that now, but I'm hoping that if anyone cares to, please feel free to reach out to Dr. Rosenthal or Dr. Doherty. I know that they would be happy to address
Absolutely.
your questions beforehand, before you kind of step over the boundary. That it's not, in this case, it does not apply that you do it now and ask for forgiveness later. It doesn't quite work like that. Definitely want to make sure you get approval now, get the blessings now. I'm just taking a look to see if there's any other items. I do see that Vana has added some things to the chat as far as our upcoming March 8th Enrichment Seminar Series, Innovative Ways Using Social Media Platforms. We also have announced that we do have our Community Engaged Research Pilot Grant that was just announced. As you leave this seminar series, your browser will open with a survey, satisfaction survey, and we hope that you would take some time to complete that and add any recommendations for future presentations. And with that, I don't see any hands raised and I don't see any further questions. And I don't see that anyone wants to make any comments. So, Dr. I guess I do see a question here. Let me just go back and see if I can find that in the chat. I'm just scrolling all the way back up.
I think the question was, how do you suggest trying to find community-based research partners?
Well, one thing I did not mention, and I thought about mentioning it, and I totally forgot. The ICTR actually has one of our cores of service is the Community Engaged Research Core, and that is through the Patients Program. And I recommend that if you have questions about engaging the community, how do you find those community partners for your project? It would be helpful if maybe you would apply for a consult with that group. They've been wonderful. They have been servicing a lot of the faculty on campus through the ICTR, and the ICTR will cover some free hours of service for them to consult with you. So if you go to the ICTR website and you look at investigator resources, one of the options will be the Community Collaboration Core, Community Engaged Core through the Patients Program. And along with that, we also have part of that core is from the School of Social Work as well. We have leadership there. We have leadership, Dr. Tom Oates from the School of Dentistry. So we try and bring in several entities across the campus that have some experience with engaging the community, and they work very closely together with the patients program. And if you have any questions, feel free to email the ICTR navigator at ICTR-navigator@umaryland.edu. And with that, I don't know that I have, how do you apply for a consult? The best way to apply for a consult is actually through the application system, which is on the ICTR website. And what I'll do, I'll put this on here now, specific for the, I'm going to do this, and this is just for the core, the community core, right here, this link here. And I'll send this to everyone. And this takes you right to our community collaboration core page. Lisa, did that help? I hope. Okay. If no one has any other questions, hope everyone enjoys the rest of the afternoon. And again, thank you so much, Dr. Rosenthal, Dr. Doherty, for taking the time to do this. It was really, really wonderful to have this presentation. And we, sometimes it's good to repeat the message, so we might be re-inviting you again. Take care. Have a great week, everyone.
Thank you very much.
Take care.
Thank you for the
Thank you.
opportunity.
Bye now.
Bye.